Good evening, everyone. Good evening, sir. So, starting with the case, a 13-year-old boy studying in 8th standard, residing in Faridabad, presented at a hospital. The history is given by the father himself, with the chief complaints of vomiting from past 4 days and darkening of urine from last 1 to 2 days. Patient was apparently normal 4 to 5 days back when he had 2 to 3 episodes of vomiting, which was non-projectile, associated with food particles, and there was no blood or bile stain. It was associated with pain abdomen, which was more in the upper abdomen, above the umbilicus, colicky in nature, intermittent, and precipitated by the intake of food and no relieving factors. He gives history of intake of outside food prior to 2 to 3 days of this presentation. There is no history of loose stool, fever, loose stool or diarrhea, fever, or difficulty in swallowing. There is no history of cough, sore throat, headache, blurring of vision, or involuntary movements. No history of joint pain, skin rashes, or recent vaccination. Vomiting and pain abdomen continued for next 2 to 3 days, for which he was managed at home with the oral medication. That is, father told that he gave him pentopin or ondansetron. There is no history of NSAIDs during this time. During this time, he also complained of dizziness and generalized weakness. Following this, he noticed darkening of urine, which he brought notice to his parents, and then they consulted a nearby hospital. Also, by this stage, he complained of passing a little less urine as compared to the previous days. There is no history of dysuria, frothyuria, or increased frequency of micturition. So he visited a nearby hospital where he was managed with IV fluids and IV antiemetic and pantoprazole. The father over there was also informed that his child is having jaundice along with anemia and renal dysfunction. He was also informed to have low platelet counts. He recalls that his serum creatinine was informed to him at around 3 milligrams per deciliter. And he was also advised for admission over there. However, he presented at our hospital. So, birth history. It was a full-term delivery, C-section. The birth weight was 2.7 kgs. There was no developmental delay. And child currently performs good both in academics and sports. Past history. He had history of intercurrent illness for initial 2 years of life, which included fever and vomiting, and it was usually managed with oral medications. History of bedwetting till the age of 3 years. Personal history. He is vegetarian by diet, normal bowel habitus, and he complained of dark color urine from past 1 to 2 days. There is no significant drug history or allergic history. In family history, there is nothing significant in family history, no renal disorder or associated symptoms in the family. History wise. So,
this is just one comment about your history. Can you present a full positive history and then go to negative history?
okay, sir.
So what you have presented is patient has vomiting, then you brought in pain in abdomen,
Yes, sir.
okay, dizziness and weakness. And then in between you said some negative history of involuntary movement, and I mean it's very difficult to figure out what is going on in your mind.
Okay, sir.
Then you came back to dark urine. Okay. Did he have hematuria or no hematuria?
No, so he said actually dark color urine, so it was basically a hematuria.
No.
Dark
It may
color
not be
urine,
hematuria.
yes, it may not be, we cannot say.
So what else, how will you find out what type of urine was it?
Sir, on whether it was on standing or...
No. Whether this is hematuria, dark colored urine, say somebody who has, for example, this patient has vomiting and pain in stomach, let's assume that he was dehydrated.
Yes, sir, high color.
So the patient who becomes dehydrated will also pass dark colored urine. But that dark color is different than the dark color which occurs in hematuria. Because if he has hematuria, that will indicate probably something going on in the kidney, like glomerular disease, right?
Yes.
So, how do you differentiate that in history?
So, number one, the urine, the color changes in urine could be because either of some food intake. So, we'll ask about any such food. Drug history is important.
Dark color, all of us have experienced. Whenever we get dehydrated and we drink less fluid in hot weather, it becomes dark. But it is just slightly dark. For example, if I have to give an example, I'll say, okay, darker than this wall, or it is like this.
Yes.
So that is dark color.
Yes.
But once you want to elicit a history of hematuria, whether it was tea colored or cola colored or brown colored urine, and the quantity, how much was the quantity? He said just some decrease in urine output.
Yes.
Like how much? How often did he pass urine?
Sir,
in a day?
the last
How
day.
much was the quantity?
Yes, sir. So during the daytime, usually he passed around 4 to 5 times, and night time it was just 1 to 2 episodes. And the last day when he complained of this darkening of the urine color, he said that he had passed urine since that afternoon only late evening, only 1 to 2 times.
Okay. And this urine was not like cola colored or tea colored urine.
So the child actually said it was slightly dark in color.
Okay.
It was brownish, towards the brownish color, he said.
Yeah. So the dark yellow or say concentrated type of urine, not exactly the gross hematuria or tea colored urine. If I understand what you're trying to say.
So he actually said a little dark color urine, dark.
Okay.
I actually may have not asked him for exact color, but yes,
but
he said it to be a very dark color urine. Like,
that is important to differentiate in such patients.
yes.
Right?
Yes.
So you said like decrease in the urine output. So the quantity was like he was saying less of the frequency, or every time he's passing less amount of urine as compared to the previous one, or if he's passing less urine, any associated like new findings of any swelling on the feet or periorbital swelling or difficulty in breathing, something like that. That history is missing. In this way.
Yes, sir. No, sir. Only for since the history of decline in urine output is of only just few hours. Like since the morning till afternoon, he has noticed it, and he had passed only 1 to 2 times. He said the quantity he did not tell exactly, but the number of frequency, as per the frequency, the childhood it was less, just as till the previous few days as compared to the previous few days. And by the evening, he had already then consulted to the hospital. So later on,
It is just like one day history, so
yes,
we really can't comment.
yes, sir. But yes, there was no complaint of shortness of breath, sir.
No edema, no shortness.
No, sir. No edema, no shortness of breath. Actually, history he gave is only very just within 3 to 4 days history.
Yeah. So even that is important.
Yes, sir. That is
Whether
important.
he
Yes, I
started
should
with
have
edema or
mentioned
shortness
edema.
of breath
Yes.
or not.
Yes.
And what Dr. Nandani is asking, you can ask about the quantity of urine. And
Yes.
he will not tell you exact how many ml,
Yes.
but you can just ask them, okay, if you compare it to the previous amount which you used to pass, उतना ही था, कि बहुत कम था, आधी कटोरी यूरिन था. I mean, that's how you can at least have some rough estimation whether it was really very less or it was like almost a normal quantity of urine.
And in the negative history, like you have said, no joint pains, rashes. Okay, so what you are trying to correlate?
Sir, any autoimmune cause, plus he's young, so if there is any, because he had further complaint of dark color urine, so that is why I just wanted to make sure whether there was any other autoimmune causes involved, or considering possibility, in rare cases, sickle cell. So that is why I got joint pains. Basically, I wanted to rule out autoimmune or also infectious causes. Sometimes patient can have infective arthralgias as well.
What do you think you're dealing with in this patient? In this stage?
So history-wise, patient basically had presentations of vomiting and pain abdomen, which was followed by a dark color urine. And as the patient's father was informed that he had jaundice and anemia with along with low platelet count, so I would like to keep a probable diagnosis. Differential diagnosis are multiple. I would like to keep acute kidney injury post secondary to infections as number one. Or
what type of infection?
so infection, considering this age, infection there could be multiple reasons. Either it could be related to malaria or dengue even leptospira because there is jaundice. And
What is against infection?
in fact, what is against infection? Okay, there is no history of fever, number one thing. And there is, if we say leptospira or rickets, there was no skin rashes, there was no any changes observed on the skin by the parents. And basically, majorly
so
there was
he has a
no.
very short history of
Short.
3 days.
Yes.
So if you want to bring infections, so with these kind of infections of malaria or the study, so fever is a predominant feature.
Yes, sir.
So if fever is not there, so
I think what you should do at this point of time is the syndromic diagnosis, right?
Yes, sir.
So since this history is very brief, as you said, 4 days, apparently the 4 days history, there is no indication of any long-term or chronic disease. So this would be probably acute kidney injury,
Yes.
right? Among the acute kidney injury, what type of acute kidney injury? Whether you are dealing with pre-renal or renal or post-renal or renal, glomerular disease, interstitial, acute.
Okay.
If I understand AKI, you mean ATM, right? Acute tubular necrosis.
Yes, sir.
So whether you are dealing, what type of acute kidney
So there is
injury?
possibility of even pre-renal AKI
What do you
because
think
patient had history of multiple episodes of vomiting. So that could have resulted in the low circulatory volume, and so that even there could be it could
So
be
you
a
think it
pre-renal
could be
AKI.
pre-renal AKI?
It could be pre-renal AKI.
What is your possibility? First possibility. So again, I'm telling you.
Yes, sir.
So what you are dealing with? Just tell me what you think he has, and then you can tell other things which he can have.
Okay, sir. So, so acute child is having acute kidney injury, or it could also be, although the duration is very short, it does not correspond, but still there is a possibility on the symptoms that it could be a rapidly progressive renal failure.
Okay.
So what is the difference between AKI and
Yes,
RPRF?
So AKI is a short duration, whereas RPRF basically the symptoms develop between days to weeks.
And in AKI?
In AKI it is within 7 days.
It can be in hours.
Even in hours. Even in hours.
Hours
Yes, sir.
to weeks.
Hours to weeks.
Weeks to days.
Yes, sir.
Okay, so that is the difference between AKI and
Let us first put the diagnosis. So you think it is AKI, or
AKI.
as a second possibility, you think as a syndrome it could be RPGA.
RPRF.
There is nothing like RPRF.
Okay, sir.
What is RPRF?
So I mean there could be either the cause could be glomerulonephritis or even there could be vascular causes for the presenting
is
symptoms.
it some change in the nomenclature of such illnesses? What is acute kidney disease? Are you aware of this? AKI, AKD and CKD.
Yes, sir.
What is the difference?
Sir, it is basically the reversibility of the presenting condition according to that.
It's basically a time frame. So the AKI is generally synonymous with acute tubular necrosis.
Okay.
As you said, it generally develops within hours or days, usually less than 7 days. You can date the event. There may be some preceding event which will precipitate kidney injury, and the patient will present with acute kidney injury. Sometimes the history is not this typical. The patient will not be able to date you exactly. Okay, इस दिन ये हुआ उसके बाद से ऐसा हो गया. या 8-10 दिन से थोड़ा ill health हो रहा था, vegetarian कम हो गया, फिर swelling आ गई, then I started feeling pucation, all these things. So you are not exactly sure whether that illness started 7 days early or 10 days or 4 weeks, right? So insidious onset of illness is there. Although it is not like CKD that you have an illness existing or probably existing for more than 3 months. So that way it becomes CKD. If it is not AKI, in between CKD and AKI, now people call it AKD, which you are trying to call RPRF. RPRF is not in any textbook or any scientific literature. This is just a term which is very loosely used by clinicians, especially in India. Right? So RPRF generally otherwise is considered synonymous with RPGA. Okay. So you want to say it could be AKI or AKD,
Yes, sir.
acute kidney disease.
Yes.
What else?
Thirdly, sir, based on the history, it could also be hemolytic uremic syndrome.
Okay. So where will you put it? AKD, AKI, where?
Sir, hemolytic uremic syndrome, it can present even as AKI, but the vascular phenomena can even further exaggerate and result in RPRF-like presentation, if not.
So I would rather keep it as AKI. So coming on to AKI, what do you think is the cause of this AKI? So as I said, it could be pre-renal, but you still think that this could be pre-renal? Or you
No, sir,
don't know?
because he had eventually developed jaundice.
Yeah.
And
So it's very
yes.
unlikely that this is in the pre-renal
Yes.
stage. It might start as a pre-renal, but looking at the course, as you said, he has symptoms, he has decreased urine output, and as you said, he has free creatinine and jaundice and anemia and low platelets. It's very unlikely that this is still in the pre-renal stage.
Yes.
So no longer pre-renal.
Yes.
Right? Post-renal doesn't look like. There is no history suggestive of post-renal at this point of time. So among the renal cause, is it glomerular disease, acute glomerular nephritis?
Yes, sir, it can be.
Okay. It can be.
It
but,
is,
But what is your possibility?
So it can be even a presentation of acute nephritic syndrome.
So what is that? What is the typical presentation of acute glomerular disease or acute nephritic syndrome or
Yes,
glomerular
patient will have hematuria, decline in urine output. It may be associated with raised blood pressure and active urinary sediments.
Edema.
Edema.
So clinically, we are not talking of sediment right now, right?
Yes.
We are talking at the level of history.
Yes.
So history typically start with hematuria.
Hematuria.
Okay. So high colored, cola colored urine or tea colored urine, coffee colored urine. Patient can describe it in any way. So that's the usual type of urine plus decreased urine output, edema, and then patient will start retaining salt and water. They will become hypertensive, and then symptoms of hypertension like headache and pulmonary edema and breathing difficulty and all these type of things. It may be very rapidly progressing over 2 or 3 days or 4 days or within a week. So that's the typical. So in this patient, do you feel he has a presentation suggestive of glomerular disease? What is odd for glomerular disease, acute glomerular nephritis?
So there is a possibility, but as there is other systems also involved, so I would still like to keep in background of the presentation some other differentials as well.
Okay. So what?
So apart from HUS, I think it could also be just simply a presentation of some, like it can also present as acute or chronic kidney disease.
Okay. So then this is say AKI, AKD, and then acute on CKD.
Yes. Although there is no such history given by the father in the previous years, except that he had histories of fever and vomiting till 2 years, but we never know. Sometimes the features remain subtle, and it could also be acute on CKD presentation.
So when you call it significant history, say in childhood, generally that's the type of history you get.
Yes.
Every parent will tell, yeah, बच्चे को अक्सर होता था जी जरा सा सीजन चेंज हो जाता था, खांसी जुकाम बुखार हो जाता था, बीमार हो जाता था.
As compared to the other siblings or as compared to the other children of the...
The one you can ask whether he was more sick as compared to other children. What else? How many episodes of acute illness do you expect in a child in a year?
So, there could be 2 to 3.
4 to 5 generally. Right. So if there are episodes which are more frequent than that, plus the severe illness. कभी डॉक्टर ने कहा कि इसको पेशाब में इन्फेक्शन हो जाता है, ठीक है, या बहुत तेज फीवर होता है, एडमिट करना पड़ता है, इंजेक्शन लगाने पड़ते हैं, बार बार इन्फेक्शन हो रहा है, मतलब साल में 4 बार 5 बार 6 बार बीमार हो रहा है, and as compared to other siblings he is more sick, and most of the time that will also lead to developmental delay.
Yes.
Right. So just 4-5 episodes या उसको vomiting होता था, घर पे दवा दे देते थे, ठीक हो जाता था. I don't think that is very significant. That is generally seen in all children. कहते हैं ना जब वो दांत निकलते हैं बच्चों को डायरिया वोमिटिंग तो होता ही रहता है, सबको होता है. So I don't think that was a very significant illness in this history. What else? So if I put it correctly, you said this could be AKI,
Yes.
acute glomerular nephritis or HUS,
Yes.
right? It could be AKD or RPRF or RPGN, what you were saying. So among that, what do you think?
So it can be either infection-related glomerulonephritis or post-infectious glomerulonephritis or even IgA. Rare, but it can present IgA nephropathy. And
so among the glomerulonephritis, now you're saying it could be IgA nephropathy.
there is a possibility, or even associated with lupus. That is also.
So what I would suggest is that once you synthesize the diagnosis, think in these terms.
Okay.
First, think in terms of what type of disease you are dealing with. Whether I am dealing with acute tuberous interstitial nephritis or glomerulonephritis. Right? If you're thinking in terms of glomerulonephritis, for example, if there is a presentation of hematuria and of edema and hypertension, rash, then what type of glomerulonephritis? Whether it is post-streptococcal or infectious associated or IgA nephropathy. Okay. So, or it could be lupus. Since you're saying that probably glomerulonephritis is low on your card,
Yes.
so first you think it could be HUS.
Yes.
Right? What are the points in favor of HUS?
So the points in favor of HUS is there is renal dysfunction, anemia. He is found to have jaundice, and on the history basis, he has jaundice, anemia, and renal dysfunction.
And low platelet.
But so history basis,
तो ये तो हिस्ट्री में तो आपने बताया है
हाँ,
तो
low platelet
बताया नहीं है
count.
ना डॉक्टर ने
Yes,
कि आपको
yes.
एनीमिया भी है
low
जॉन्डिस भी है
platelet
टीम
count
भी है
also.
लो प्लेटलेट
Thrombocytopenia.
that's the reason you are making
Yes.
HUS as a
Yes.
possibility. Otherwise, what type of history do you get? If you're not aware of these doctors' finding which was told to him,
Yes.
would you keep HUS as a possibility?
Yes, sir. Because he is considering number one his age, number two very short and brief history he has come with.
So
And
then
What is
the
predicted?
pre-renal is the diagnosis if you don't have the history of jaundice, anemia, low platelets,
Yes,
and
sir.
renal dysfunction. So then the patient comes to you with all these findings. So obviously first is the pre-renal.
Yes, sir.
So without this history you cannot go to the diagnosis of HUS or something like that.
So, what type of history do you get in HUS? If you're saying HUS, now let's assume that this is HUS, then what type of HUS? Why did he develop HUS?
So there will be history of either diarrhea. If it is infection related, the patient may say that the child had diarrhea followed by which he developed such symptoms. Or sometimes it could not be even associated with diarrhea. He just can have development of renal dysfunction, decline in urine output, or he can develop petechiae. There could be skin changes or pallor.
So why do they develop that type of HUS without diarrhea?
So it will be atypical.
Yes. So it could be diarrhea associated
Or
DHUS, or it could be AHUS or atypical HUS.
Yes.
So what do you expect in
In
children?
this patient,
So
based on the
as
history, what is like
yes.
diarrhea associated atypical.
So as there is no history of diarrhea, it is indicative likely of atypical, but still some patients with even present with diarrhea negative STEC associated hemolytic uremic syndrome. So that completely we cannot rule out, but yes, it is more likelihood of that it is a atypical HUS.
In this patient, you did not have any history of diarrhea.
No, sir, no history of diarrhea,
No fever.
no fever, no diarrhea.
What is typical of diarrhea in HUS? What type of diarrhea?
Bloody diarrhea,
Dysentery diarrhea with blood. So if you don't have that history, obviously you have to test for the Shiga toxin and all, but very rarely, as you said, sometimes you do not have history of gastroenteritis and still they can have DHUS. Or it could be atypical HUS. So why did he have atypical HUS? Why would he have developed atypical HUS?
It could be a genetic predisposition, sir. There could be some the factors which are responsible for activating the alternate complement pathway. That could be on. It's basically a complement mediated. So he could be predisposed. Normally, also there is some generation of these the molecules involved in the alternate pathway which are kept in control by the regulator. So if there is any mutation of this regulator genes, the patient is predisposed, and even a secondary hit can result in.
So what was the second hit? So what was the second hit in this child?
No sore throat?
No sore throat. There was no infective history he was giving, but still he had a history of taking food outside. But yes, sir,
They
it's
have food
not a
outside.
food diarrhea.
13-year-old kid have to have food outside.
So you will have to support your diagnosis with something.
Yes, sir.
So patient is not having diarrhea.
Yes, sir.
So you are saying it is not diarrhea associated. Patient is not having any history.
Yes.
So why you are coming like atypical? What is the secondary hit?
Yes.
So there is nothing which supports the diagnosis. Why it is initiated? There should be something precipitating or initiating factor or something like that.
In what setting do you see atypical HUS commonly?
Oh, sorry, sir, I didn't understand the question.
What are the causes or how do they present atypical HUS?
So atypical HUS, they have similar presentation. There won't be a history of diarrhea, but they will develop renal dysfunction. They will have low hemoglobin levels, or they will have developed hemolytic anemia.
Anything which can precipitate endothelial injury.
Yes, sir.
So what are the second hits, common second hits?
Common are infections itself, sir.
One is infection.
Yes, sir. And
Pregnancy,
drugs, it could be because of drugs.
Malignancy.
Drugs,
These are different.
malignancy.
Malignancy, drugs,
And
transplantation.
transplantations.
Commonly you see it in terms of pregnancy. It's
Pregnancy.
typically seen in terms of pregnancy, that after pregnancy or delivery details of this. So that predisposes them to endothelial injury, and that is the second hit which will be there. So in a male child at 13 months, just 13 years, very unlikely to be atypical HUS at this point in time, without any significant family history.
So if you want to come in like if the vomiting and everything was as a feature of uremia, then it could have been like advanced disease with previous symptoms. The child would have been ill for so many days to progress to anemia, and it will be a gradual
Yes,
disease.
sir. Yes, sir.
Taking some days to weeks, not it is like 3 days history or something like that. So that is again we have to put in consideration.
The third possibility which you kept was infection.
Yes, sir.
So how will these infections cause acute kidney injury? Which you were naming as malaria, dengue, leptospira.
So intrinsic basically, intrinsic kidney injury they can cause. So they could be membrano-MPGN type of
LPG.
malaria associated with malaria.
Have you seen patient of malaria who has come with? How does malaria cause acute kidney injury?
So hypovolemia or hemolysis.
How does malaria cause acute kidney injury? You must have seen a lot of patients with malaria and acute kidney injury by now.
During your MD days.
Hemolysis itself can cause.
One, when you say black water fever or hemolysis, severe malaria, excessive intravascular hemolysis, and you see pigment-induced acute tubular necrosis again, right? So hemolysis can cause acute tubular necrosis in these patients. And बाकी भी जितने फैंसी मलेरिया देखते हैं ना जिनको एक्यूट किडनी इंजरी होती है क्यों होती है?
Shocks and hyperperfusion.
शॉक क्यों होता है?
Third spacing.
थर्ड स्पेसिंग. व्हाई थर्ड स्पेसिंग?
Capillary.
कौन बोल रहे हैं?
कैपिलरी
हाँ
लीक
हाँ कैपिलरी लीक क्यों होता है?
सर ऑल द मतलब जो मलेरियल एडहेजन है वो कॉम्प्लीमेंट मीडिएटेड पाथवे को एक्टिवेट करेगा, तो वो जो कैपिलरी बेसिकली इन्फ्लेमेटरी कैस्केड के थ्रू कैपिलरी लीक होगा. Third spacing.
So they induce something like systemic inflammatory response syndrome (SIRS), excessive burst of inflammatory mediators, and that causes endothelial injury, capillary leaky capillaries. So they have the relative hypotension, what you were saying, and shock associated acute kidney injury, again ATN or acute kidney injury. Number two, the malarial infested RBCs, they become bigger and they block the capillary perfusion. So impaired capillary or blocked capillaries, impaired perfusion can again give rise to ischemia in the borderline zones, watershed zones. Okay? So these are the mechanisms how malaria causes. And at times it may also cause HUS people have reported, especially there is a series from All India Institute, that patient who come with severe malaria and acute kidney injury. Some of these patients, when they do not recover, they did biopsies, and in fact, some of these patients had HUS on kidney biopsy. So that may again be because of malaria-associated diffuse endothelial injury, which will start these complement cascades, especially if they have a genetic predisposition for atypical HUS. That's a common, so it's not like MPGN. MPGN is not a common manifestation. So that is generally seen in patients who have chronic malaria, which is not seen in this part of country. Either some South India or other African countries where these patients have chronic malaria infection and antigenic exposure and complexes are formed and MPGN or membranous type of nephropathy. So they will present with nephrotic syndrome type of injury, not with acute kidney injury. Right?
So the second infection you said was dengue. So everything can be explained by the dengue. So
Yes,
you can have the jaundice, you can have renal dysfunction, you can have low platelets, you can have microangiopathic hemolytic anemia causing severe anemia in these patients, and they may just present with the constitutional symptoms.
yes, sir.
So they may have low grade fever which might be missed. So jaundice, anemia, microangiopathic hemolytic anemia, thrombotic microangiopathy causing renal dysfunction, low platelet, everything can be explained by the just dengue fever in this patient.
So that all these things like leptospira, dengue, malaria, they will cause acute kidney injury like acute tubular infection. So that's what. So when you, if I have to put the diagnosis in this patient, that's how I will consider. Looks like acute kidney injury. Among acute kidney injury, my first possibility would be acute tubular interstitial nephritis, because there is nothing to suggest, or say not much to suggest glomerular disease per se. The first possibility I would keep is acute tubular necrosis, tubular interstitial nephritis. Okay. Secondary to probably infection, as you said, or severe volume depletion. Again, severe volume depletion is very unlikely. In a young child, 13 years of age, just few vomiting should not give rise to such a severe volume depletion to give rise to acute kidney injury. There has to be something else.
And he got like medical attention within
2-3 days.
2-3 days. He was given IV fluids.
So
So that was not that he has not received the medical attention. So he was managed. So that is why the severe dehydration is unlikely in this patient.
second possibility, I would again keep acute glomerulonephritis in this patient, although the patient does not give history of, say, gross cola-colored urine or edema, but it could still be acute glomerulonephritis. Third possibility, I would keep HUS. Number one, there is no history of diarrhea, which is commonly seen in patients or say children who present with diarrhea-associated HUS. Atypical HUS is a possibility in this situation, but then you do not have any reason why he would develop sudden atypical HUS without any precipitating event. Right? That probably how we get. Acute kidney disease or RPGN, generally again the history is more insidious. So over say 8-10 days and gradual. And most of these patients, if they present with severe renal dysfunction, they will also have edema and decrease in output. Right? So how do you differentiate between acute glomerulonephritis and acute RPGN clinically? Acute glomerulonephritis, I would make post-streptococcal glomerulonephritis, or whether this is RPGN. Clinically,
Edema
edema will be there.
and hypertension
So hypertension will be present where?
in RPGN.
RPGN, it is more common. There is a dictum in clinical medicine. Whatever you think is right is usually wrong. So you just reverse it and say. So 90% times you will be right.
So post-streptococcal, as I was saying, acute nephritic syndrome. So that hypertension is a part of that.
Hypertension is part of that.
RPGN, the hypertension is due to
Fluid and salt retention.
Again, it is
So it
due to
takes
fluid
time.
and
Takes
salt
time.
retention in both, but generally in RPGN it is mild. It is not there or it is mild. Whereas in acute glomerulonephritis, it is more marked. Right? So if you are finding patients who have features of glomerular disease, acute glomerular disease, but the onset or is little slower in CVS, hypertension is not that marked, although they have decreased urine output and edema, but the blood pressure is not very high. plus they have anemia associated. So that probably will point you towards RPG and then acute bronchitis. Right? Anything else you had in mind when you said RPRS?
No, sorry, related to infections.
Why are you saying acute and chronic kidney disease?
So acute and chronic disease, because sometimes the features the patients present, their presentation is very late. Especially kids, sometimes they tolerate well, and even the symptoms oral sometimes goes unnoticed because they fail to tell it to their parents. So that could be a possibility. Still, we cannot rule out until otherwise investigated further.
So,
Although it's
but then there will be other telltale evidence of chronic kidney disease.
yes, sir.
What do you find? What evidence can you have of chronic kidney disease in children?
Yes, a patient can have lethargy, decrease.
They're very non-stressful.
Okay, so there could be increased frequency nocturnal aneurysms. They
Okay.
start with nocturnal aneurysms.
Why do they develop nocturnal aneurysm?
So the action of aquaporitins cannot take place because of the damage. The aquaporitins fail to act.
Okay.
The
So what?
receptor surface receptor. So because of that, they cannot hold water or absorb, and that is why there is nighttime diuresis.
Why not daytime diuresis? Why only nighttime
So
diuresis?
because in the day the patient is awake, so the osmolar.
So there is difference between aneurysm and nocturia. आपने अभी बताया ना nocturnal
Yes, sir.
aneurysm and nocturia.
Yes, sir.
Are they different or same?
So one is increased frequency and and amount as well. The other one is having increased episodes of the urine in the night.
So they will pass urine in bed. So nocturnal
Yes.
aneurysm is bedwetting. They are not aware and they will pass urine in
Yes.
the bed. Right? It happens in children because they are small and they can't control. They don't have that feeling of urgency and they can get up and do. So they pass urine in the bed. So that is they lose control. Most of these children they gain control, bladder control within 1.5 to 2 years or maximum 3 years as you said in this time. But if after that they start having say these incidents in night or nocturnal aneurysm, that may suggest. But that is one thing. In adults also you get history of nocturia in
Yes.
chronic kidney disease. Why do you get nocturia?
The same phenomena. So
The
because-
same नहीं अभी तो आपने बताया नहीं. I don't know what is same. Why do they get nocturia? आपने कहा night में frequency बढ़ जाती है.
Yes, sir.
Why not in the daytime?
So it is related to aquaporin action itself. And,
What is the action on acrocord? Why does it happen only in night, not in the daytime?
so
Anybody else?
if the patient is awake, the release of vasopressin.
Let anybody else know.
Loss of concentrating abilities. Loss of concentrating.
So what happens?
There is tubular atrophy basically.
Yeah, no, I understand there is loss of concentrating ability. But why only in the night time?
Because the patient is awake in the day, the patient is passing in at night time.
So when do you call nocturia?
More than once awakening to pass. It is not true. So at night
So-
time you should be able to concentrate and hold it back. But if it is not concentrated, then you have to pass for the motive. You should get up. So it is not true.
What is isostenuria? Have you heard this word? Isostenuria?
Osmolarity will be same as
As
specific gravity.
osmolarity will always be same as specific gravity. What is osmolarity?
I mean, so the concentrating effect of urine fails in.
Yeah. No, but what does this term mean? Isostenuria. Iso means what?
Same
Same. Astenuria is osmolarity.
osmolarity.
Same osmolarity
Blood,
as
C
blood. Yes. So it's not like a specific gravity. So the urine will have same osmolarity as blood. Okay, which happens in chronic renal failure because the kidneys cannot concentrate the urine. So the blood osmolarity is usually 280 to 300. Urine will also be 280 to 300. Right? What happens normally in the night is you don't drink water, the urine gets concentrated. Your bladder will keep collecting urine. In the morning when you get up, you go for the urination. These people, they cannot concentrate urine. So every time there is 400 ml of urine in bladder, they have to get up and pass urine. Okay. If somebody is taking normal osmolar load, which is generally how much? What is the normal osmolar load? How many osmoles do you pass in the urine per day?
6,000, sir. 6,000 maybe.
6,000. No idea. No idea. No idea. किसी को है idea?
500 to 600 milliosmoles.
Yes. So whatever you eat, salt and protein, they are digested and they will convert into osmolytes, right? And you will pass. And the normal Western diet, it is approximately 800 milliosmoles. In Indian vegetarian diet, although protein content is less, but the salt content is high, so still 600 milliosmoles, right? If you have to pass 600 milliosmoles in 24 hours with a osmolarity of 300, which is equal to blood, how much urine you will pass? 2 liters?
Okay.
Isn't it?
Yes.
So you have to pass 2 liters. Same rate in the daytime and in the night time. So daytime you are awake, every 4 hours you go and pass your. Same 1 liter urine when you have to make in the night, you have to get up at least twice in the night. 400, 400 and then in the morning. So that's why you have to get up in the night. It is related to aquaporins and all what you are trying to say, but there is decreased concentrating ability in the broad terms. You can't concentrate that osmolarity gradient in medulla, and that's why you can't concentrate urine, and you have to get up in the night. So nocturia can be there, nocturnal enuresis in children and nocturia in men. Decreased growth. Say, any children, even if they cannot tell, their growth will tell you. Okay? If child has significant renal dysfunction, he will have growth retardation or renal rickets or evidence like that. Right? Unless until he has a very mild dysfunction. His kidney disease is not that bad, that's the reason he does not have any growth impairment or any telltale symptoms of chronic kidney disease. Then again, any acute, so whatever, I have to put what you're trying to put is, patient may have very mild chronic kidney disease, which was not obvious, but even the mild dehydration associated with vomiting can have precipitate acute kidney disease, acute and chronic kidney disease. And that is why it is kept as a third possibility. Right? That is your escape route. Unless you don't find anything else, and in the end you find that patient has small kidneys or something else leading to chronic kidney disease. So this is your escape route. And that is why it is in the third position. Do you understand?
Yes.
It's important how you think about and synthesize your diagnosis and then go forward.
Even in that case, like you said, acute on CKD, you will have to tell them what is the acute factor based on your history again. So that is all the things that I told you about the CKD, that is all okay. But again, your anemia, low platelets, so that you will have to summarize or support your diagnosis of the acute kidney injury on chronic kidney disease.
Acute on chronic kidney disease, you have to tell what is the probable cause of chronic kidney disease in this child and what is the acute insult which has happened.
Acute insult, I consider it could be acute gastritis, and chronicity could be because of CIN. There is a possibility.
CIN. How
So-
common is CIN?
Or we
CIN
can yes, sir.
again is an incomplete diagnosis.
Okay.
CIN has to have a cause.
Reflux nephropathy.
Reflux nephropathy is not CIN.
That is reflux now.
What is reflux nephropathy?
So because of any tract abnormalities, there is reflux of the urine from the
A
bladder.
psychouritic
It was
reflux in the
yes.
childhood. So what happens to these reflux?
So they create a back pressure, and
Back pressure.
so initially there is either the reflux is till the ureter or to the renal pelvis, then there is dilatation of the ureter or the pelvic
That's
system.
That is the grading of reflux.
Yes.
Okay. So there are generally what? 4 grades, 5 grades?
Five.
5 grades. Some people say 4, some people say 5. It's still alright. So that's how you grade how severe is the reflux. Okay. What is reflux nephropathy?
The changes because of the pressure.
There is no pressure in reflux.
chronic pyelonephritis.
Pyelonephritis. Anybody else? Ah, wait. तुम ही बताओ भी अंकित. What is reflux nephropathy?
Sir, basically chronic insult to the this. It basically results as a renal cortical scars.
Yes.
Scarring.
So you have upper pole scars, lower pole scars
So
initially.
you may have scarring in the kidney because of reflux at some point of time. Okay, that causes scarring or damage to the renal parenchyma. And where do you see these scars?
Upper pole, most probably.
Upper pole usually, not on the lower pole. You may see it in upper pole. Why on the pole?
Compound papilla.
Huh?
Compound papilla.
Compound papilla. So what is simple papilla and what is compound papilla? आपने पूछा मैंने नहीं पूछा. You know what is simple papilla and what is compound papilla? क्या
Only
बोलते हैं?
papillate and
हाँ?
no.
You don't know it? हाँ तुम ही बताओ.
I think इसकी structure में कुछ difference है.
कुछ different. Okay, चल.
ये पेपिला एक उसमें pelvis में ड्रेन करता
No, papilla is there, but it's a refluxing papilla. So why do they develop damage? Because it's a refluxing papilla. Instead, in addition to vesico-ureteric reflux, there is also intrarenal reflux. Okay. So when the urine reaches pelvis, it also reaches inside the renal parenchyma, and that causes inflammation in the renal parenchyma, and that leads to scarring of that. And usually at poles, you develop these refluxing papilla or compound papilla. However, as the children grow with age, these papillas become non-refluxing. And that's why when these children develop reflux, they usually develop in the early stage. Okay. In later stage, if the patient have repeated infection, if they continue to have high-grade reflux, they may have repeated infection and pyelonephritis. And that again cause scarring of the papilla and deform these papilla. Okay. And then they develop further scars in the later stage. But if they do not develop these infections, they will not develop further scars in the kidney. Even without infection, because of chemical inflammation, these patients can also develop scars. And most of the time, by the time you diagnose the first vesico-ureteric reflux, children already have scars. Okay. Number two, there is some evidence of dysplasia, renal dysplasia, because it's a congenital disorder. Why do they develop reflux? The same episode, they can also develop dysplasia in the kidneys. So they have underlying dysplastic kidneys, which later on manifest as renal dysfunction. So the reflux nephropathy is scarring of the renal parenchyma, which is associated with current or fast reflux, vesico-ureteric. Most of these reflux they disappear as the children grow. 80% reflux disappear by the age of 1 year. Right? So it may not be there when you diagnose reflux. If you do an ultrasound in this child and you find that there is scarring, he may not have reflux now, but he has had reflux in early childhood that has led to deep reflux. Since the scarring was less at that time, other renal parenchyma was functioning, he never had any symptom. Most of these children will present in late adolescence or early adulthood. Okay. Women generally present in pregnancy. This is the first encounter of women to medical system, healthcare system, and that's when they are diagnosed to have proteinuria or high creatinine or hypertension, and that's when you diagnose, okay, this could be reflux nephropathy. Men generally they present in 18, 19, 20 years, they will present with advanced renal dysfunction or some manifestation. Okay. But whatever, it was a mild renal dysfunction if at all, and over and above that there is acute insult. Examination.
On clinical examination, the blood pressure reading was 126 by 80 mmHg.
So this is a 13-year-old child.
Yes, sir.
Any height, weight, BMI?
Yes, sir.
Get.
So heart rate was 94 beats per minute and respiratory rate was 22 cycles per minute. His height was 160 centimeter, which was 75th percentile, so it was in the normal range, and his weight was 50 kgs, again lying between 75th and 60th percentile, and BMI of 19.5 kg per meter square. On head to toe examination, there were no hair loss, no graying of hair. He was found to have pallor, and icterus was also noted. There were no clubbing, cyanosis, hidden edema or sacral edema, no lymphadenopathy. And also scanty petechiae was seen over the trunk and bilateral lower limb. And normal genital examination was normal, there were no genital abnormalities. Coming to systemic examination, the patient
So
was
whether the child was dehydrated or not dehydrated?
No, sir. While presentation, on presentation, he did not appear to be dehydrated.
How do we find whether he is dehydrated or not?
So skin turgor, capillary refilling time, and sunken eyeballs.
If it is mildly dehydrated, you will not have these frank features of dehydration.
Oral mucosa, we can dryness of the oral mucosa.
Then
Low blood pressures,
Pulse volume,
pulse volume, feeble pulse,
thready pulse.
feeble thready pulse,
postural hypotension.
posture. Yes.
Saying that may be the only feature. If the patient is grossly volume depleted, severe dehydration, then you will find all these features, sunken eyes and everything. But if it is not severe dehydration, it's important to look at the blood pressure in lying down and in the standing position.
So, systemic examination, patient was conscious oriented to time, place, and person. Respiratory examination, the trachea was central, bilateral chest expansion symmetrical, and no skin changes. On palpation, there was no local rise of temperature or no mass was palpated. The expansion was equal on the bilateral chest fields.
Positive find any systemic?
In sir, abdomen, I would say they were negative, but still they are contributing to our case history. In abdomen, number one, on looking, they were on inspection, petechiae were present, umbilicus was central, and all the compartments were moving equally. And on palpation, there was no local rise of temperature, there was no tenderness, and there were no organomegaly. So, rest other examinations were normal.
Unremarkable. You didn't find any evidence of chronic kidney disease on examination?
No, sir, no as.
You said patient had pallor,
Yes, sir. Pallor was there.
but otherwise,
No skin or no nail changes, no brittle or dry skin, or no changes in the hair,
what type of changes in the head?
brittle hair or
These are things of malnutrition.
malnutrition.
Rickets? Because in children, that is another feature which should be very prominent. The rest of the things like skin changes and nail changes and hair changes, they are usually mild. I would say evidence of malnutrition rather than a real change of renal failure. The only thing is which will indicate chronicity in examination would be pallor. If the patient is pale, and which anyway he is
Yes.
for many other reasons, or you find the changes of rickets. So what did you look for?
So chest, there was no bony cage deformity. There were no deformities
What-
noted in the
what-
bilateral lower limb or the knee
What
joints.
deformity? What deformity?
Regular
What deformity do you see in the chest?
So there will be the costochondral junction tenderness, or there will be swelling slight or tenderness in the costochondral, or the rib cage appearance also could be
What is that appearance?
excavatum and
What is excavatum?
it
Pectus excavatum.
yes, sir,
Pectus carinatum.
carinatum.
What is it?
Pigeon shaped chest, the costochondral junction is just low and the sternum is more prominent.
Yeah. The sternum will stand out like this. So that is carinatum or pigeon shaped chest. Excavatum is when it is depressed. So the sternum will just go inside. The ribs will come like this and then the sternum will depress That is excavated. Rickety rosary. What is rickety rosary?
Costochondrial bleeding.
The prominent costochondrial junction. It will just come out like this, beadings. Harrison sulcus.
The diaphragm, the
Harrison.
there will be a skin, there will be a fold or demarcation could be made out because of the diaphragm movement.
कहाँ पे कैसे दिखेगा?
Below the sternum and the subcostal areas.
Yeah. So you will see some depression here going like this. Because the diaphragm is attached to these ribs, and because the movements of diaphragm and because the bones are soft, ribs are soft, they are pulled inside. So you will see a sulcus here on both the sides going laterally. So that's called Harrison sulcus. Okay. And in the head,
Frontal bossing,
frontal boss.
pain from skull. Sometimes the measures can also be open.
Yeah. So in small children, you will find that their fontanelles are not closed. But in adult 13 years, probably you won't expect that. But frontal boxing may be present. So their frontal they will become more prominent.
There can be genovalgus.
Skeletal abnormalities, genovalgum, genorecurvatum, all this can happen.
Genovalgum, varus.
Lateral malleolar prominence will be there. Double malleolus will be there.
क्या बोल रहे हैं जोसे बोल
Double malleolus will be there, sir.
double malleolus, yes,
And there will be changes in the knee as well as in the hip joints.
bowing of legs,
Going down, sir. And there will be changes in the hip as well, sir. And
what changes in the hip?
sir, hip, sir.
Hip, what changes?
Sir, it will be general coxa.
Yeah. So again, dislocation or say deformities in the pelvis.
Sternum will be narrow, so there will be dislodgement.
Sternum will be narrow, so there will be dislocation.
Yes.
And
In
spine,
in the hand also, in the distal prominence, the sides of the
fraying of distal end of radius,
Yes.
right? And in the spine. So scoliosis or kyphoscoliosis. What is children pot sign to children? Heard of pot sign? Rattling gait. In a child with renal dysfunction, all these things have to be. You should know these things. Right? Because these are the features which will tell you whether the child has chronic renal disease or not. Right? So just go and read these features. All the features of rickets in children. What are they? So, any wiser after examination? What is the diagnosis now? What did you make? I mean, don't.
Yes, sir. Sir, as a boy presented with a history of, the boy presented basically with renal dysfunction, with anemia and a background of thrombocytopenia and jaundice indicative of hemolysis. I would like to keep hemolytic uremic syndrome as my diagnosis. And probably, if as it is not associated with diarrhea, it could also be a atypical HUS.
So, in that order, you still think it is acute kidney injury because of HUS, atypical HUS.
Yes.
Any points in favor and against, in addition to what we have discussed already? The reason to keep this as the first possibility is because he has jaundice and decreased platelet count.
Yes, sir. Thrombocytopenia, decreased platelet count. And he has renal dysfunction as well and hematuria. Again, indicative of hemolysis.
So no features of CKD, so acute on CKD is probably not
Yes, sir.
case in this. So and then because apart from HUS, you said
Infection related like malaria, dengue or the leptospira stage, but there is no organomegaly,
and
no such severe history of fever, so I would like to keep this.
post-infectious GN is not now in the list because the
Yes.
patient is not hypertensive or no
Yes.
edema or something like that. So what did you find in the urine examination of this patient?
In the urine, sir, dipstick examination, the blood component was very strongly positive. In fact, in dipstick it turned black in color, and also there was presence of protein, 2 plus,
Sorry,
2 plus protein,
what else?
and there were many RBCs and pulses with 2 to 4 on routine microscopy. And on routine microscopy of urine, there were many RBCs and dysmorphic RBCs seen on microscopic examination.
How do you see this morphic RBC?
So the shapes will be altered, and
So when you see a slide and microscope, कैसे दिखता है? What alteration is it?
the irregularities on the surface. It could be the surface border could be irregular, or could be also broken.
Did you see it?
Urine, yes, sir.
Could you see it?
I could not see broken, but they were very small and irregular and too many. They were present too many in the urine.
So
Patient may have RBC, a lot of RBC.
fulfilled RBCs.
Whether they are dysmorphic or not dysmorphic.
Yes.
Why is it important? What does dysmorphic RBC indicate?
It is a glomerular. The hematuria is the hematuria is because of the glomerular causes. Yes, sir.
So it is sometimes you have hematuria, whether it is coming from a lower urinary tract or it is coming from the kidney.
Yes.
So that's how you will discuss.
What is RBC
So-
cast?
Any cast?
Sir, granular cast was seen.
What is granular cast?
So because of it is usually seen it can be seen in CKD or also some
What is granular cast?
ATM.
So in ATM, what kind
Slough. It's basically a slough. It is a sloughing. The sloughing, so it is just a.
What is cast?
So it is basically formed from the tan horse protein.
Okay.
And superadded to if there is any other deposition, so there can be changes in it. Tan horse cast could be even normally it can be seen.
Mm-hmm.
In cases of granular
Do you
cast,
see casting in normal urine?
not quite often, but it can be
Can
present.
we see when? See, normally you don't see the cast,
Yes.
but normally without a significant kidney disease you can see the cast. So in what are these conditions when you can see the cast in the urine? Without a significant kidney disease?
Crystals, I mean,
Is there a difference between crystals and cast?
yes, sir.
So we're talking of cast right now.
Yeah.
Where do the casts form and why do they form?
Tubules.
Which tubule? Proximal tubule, distal tubule.
So initiation begins in the loop of Henle and then it goes and deposits in the distal convoluted tubule.
Distal tubule.
Yes, sir.
Why do they not form normally? You said it is because of TAM horseful protein.
Yes, sir.
So TAM horseful protein is present in the urine normally or it isn't?
It is present.
It is
It
present.
is present.
But why do they not form cast? In the
Does
normal
not
urine?
accumulate.
TAM horseful प्रोटीन है जिससे कास्ट बनता है, डिस्टल ट्यूब्यूल भी है, तो कास्ट क्यों नहीं बनता?
This,
Because the flow of urine in the distal tubule is very high. So for the cast, how do the cast form? आप पानी को फ्रिज में रखते हो आइस बनाने के लिए, उसको एक कटोरी में रखोगे, एक गिलास में रखोगे, it will take its shape and it takes some time to consolidate, right? So these TAM protein are there in the normal urine, but because the flow of urine in the distal tubule is so fast, they do not get enough time to get precipitated or take a shape of that tubule to form a cast. Right? If the urinary flow is low, which happens in dehydration, or if the patient has a nephrotic syndrome where there is a very less distal renal flow, so then there is enough time for this protein to get precipitated and form a cast. So you can see these casts. Okay? And these are normally waxy casts, right? So normal. So there is nothing else, they are just protein crystal clear protein taking a shape of a normal tubule. Right? Now, if there is a disease, whatever extra material is there, that will get precipitated along with the stem of the protein. Okay? If there are RBCs, they will form RBC cast. If they are degenerated tubular cells in acute tubular necrosis, they will form granular cast. So these degenerated tubular brush powder or tubular cells will get precipitated with time of the protein and take the shape of that tubule to form a granular cast. Do you understand now?
Yes.
If there is inflammation, for example, WBCs, tubular inflammation or tubulitis, then you will see WBC cast in the urine. Okay? So whatever disease is going on, that will give a flavor to these casts or appearance to these casts. तो जो आप आइसक्रीम बना रहे थे वो स्ट्रॉबेरी बनेगी या मैंगो आइसक्रीम बनेगी डिपेंड करता है कि वहाँ पे क्या हो रहा है क्या रखा है फ्रिज में ठीक है दैट्स हाउ द कास्ट इज फॉर्म so did you see any cast in this urine
Granular cast.
granular cast so what does that mean
80 and
80 so granular cast will usually mean acute tubular necrosis in this patient so now RBCs how do you see dysmorphic RBCs generally, it's very difficult to appreciate it on normal light microscopy as we see the urine examination.
Which kind of microscopy is used for seeing the dysmorphia?
So, if you really have to find out whether these are RBCs, so you have to make some changes in the microscope.
Phase continuous microscope.
Phase contrast. Right?
That is
So against the bright light, when you see these, plus you have to see it in a higher magnification. In a usual magnification, when you see these RBCs, you just see a oval shaped or round shaped cells. It's very difficult to appreciate the abnormalities in their membrane and outpouching, which we have read in the theory, that there will be outpouching from the membrane. You can't see it on the light microscopy. Unless until you will see a higher magnification and a phase contrast, then only you can figure out. And how many should be dysmorphic? Percentage of RBCs to be dysmorphic to say that this is significant.
or in urine.
We're talking of urine. We're not talking of blood right now.
So you said na fulfilled was
Yes, it was
numerous.
numerous RBCs that
So
we see.
even if
Numerous RBCs with kitni dysmorphic thing. More than 50% dysmorphic, more than 20% dysmorphic, more than 80% dysmorphic. Sorry? So actually there is no sacrosanct cutoff. Earlier people used to say that it has to be more than 50% dysmorphic RBCs to say that these are dysmorphic. But now people say even if it is more than 20%, it is significant. So even if they are 20%, they are indicating that these RBCs are coming from the kidneys. Okay. So presence of this dysmorphic RBC will indicate glomerular disease or renal disease. It is equivalent.
5% erythrocytes in the very definition, so 40% of dysmorphic and plus 5% erythrocytes.
Or even a single RBC cast.
RBC cast anyway, as I said. So cast means that RBCs are coming from the kidneys. Cast will not form in the renal urinary system.
Urinary tract.
Cast will only form in the tubules. And if the cast, when the cast is formed in the tubule, there are RBCs, that means the RBCs are coming from the site above the tubule.
So it is a glomerular disease.
If you find RBC cast, that in itself take you directly to the glomerular disease. Isn't it? So in urine you find a lot of RBCs plus sinus from dysmorphic RBCs and granular cast. 2 plus protein. So how much do you think is this protein? Where does it take you? Glomerular disease, tubular interstitial disease? Where? 2 plus?
So high probability of glomerular disease, but it could also be seen in tubular as well. Plus, as there are RBCs, so it could be because of the breakdown of RBCs or proteinous cells.
So your urine examination is in keeping with what your diagnosis, HUS?
Sir, it is basically telling us that yes, there is hematuria, there is presence of RBCs and numerous RBCs are there. Plus, there was proteinuria observed and no infection. The
So active
WBC or
sediments are there.
yes, sir. Active sediments are there. Urine is RBCs were present, and
So it is a glomerular disease.
glomerular disease.
But
Glomerular
you said
Granular.
cast are also there. So ATM is also there.
Yes,
This
sir.
is
It
one
will be a
plus-
secondary complication as well.
1 plus 2 plus protein is non-committal. If you find 3 plus 4 plus, then probably it will indicate a significant proteinuria indicating glomerular disease.
Yes.
Okay. In a patient who has a low urine output, 1 plus 2 plus may still be a tubular proteinuria up to 1 gram per kilo per day. So this is non-committal. RBCs, as you said, may be present in any sort of disease. Dysmorphic RBC, I'll take with a pinch of salt, as you said, whether they are dysmorphic or not dysmorphic. The granular cast, if they are there, as you said, they would indicate tubular injury, acute tubular injury, so far. Okay. Now, how will you go further from here?
So we said the routine blood investigations and other.
Will you try to quantitate this proteinuria or not?
Yes, sir, we would, but also we would like to see because he has history of other.
No, that's all right. So once finish one thing first, so that's what I meant. So you did the urine examination, routine
Yes,
urine examination.
Yes, sir.
But as I said, 2 plus is non-committal. So
Yes,
we
sir.
would like to
We did
quantitate how much proteinuria is there.
Spot urinary protein to
Spot
creatinine
urine
ratio
protein
was-
creatinine ratio.
It was found to be very active, 17.
Sorry?
17.2.
Ratio was 17.2.
Yes.
Okay. Is it in keeping with your urine routine examination? Were you surprised with these findings?
Yes, sir. I found it to be very much high.
So
And,
where will you put your money? Your urine routine is right or your UPCR is right?
so
They're
right now because
not concurrent.
yes, sir.
One of these tests is wrong.
I would go with urine routine microscope, urine test actually rather than spot urine protein to creatinine ratio because
So urine
Yes.
routine, and especially when you said the patient has very significant
yes,
blood stain or dipstick, sometimes if you have a strong blood stain, it will also give stain to the
Yes.
protein, right? So the 2 plus protein probably, in my view, probably is a tubular proteinuria here, or because of severe hematuria or RBCs in the urine. So I would rather doubt this report of urinary
Yes.
protein creatinine. चलिए आगे और क्या करें? What other investigations will we do?
so complete blood count.
Mm-hmm.
The complete blood count check on the first day revealed a low hemoglobin. And he was
How
found
much?
to have 5.7 of
Okay.
hemoglobin. And thrombocytopenia, his platelet counts were 60,000.
Okay.
And he had renal dysfunction.
TLC? TLC?
CLC, WBC was 5,000.
Right.
Yes,
And differential I assume was unremarkable.
yes. And,
Peripheral smear.
peripheral smear, sir.
क्या करेंगे? चलो नहीं चल हाँ
So peripheral smear showed that fragmented cells, around 400 cells were seen per 1,000 RBCs. And ovulocytes and teardrop cells were also seen.
So what is fragmented cell? What is known as
Ghost cell. Schistocytes. Schistocytes. Yes.
So what is the percentage of schistocytes?
40% here.
40.
For calling it to be positive or significant, it should be more than 2% of 2 to 4% of schistocytes should be there on peripheral smear to consider it significant.
So then your case there were a lot of histiocytes.
Yes,
there.
sir.
Okay.
And plus teardrop cells were also there.
Hmm. What else? What else will you do?
Renal function test we had ordered, which showed renal dysfunction. His serum creatinine was 2.9 on presentation, and urea was 174, and potassium was 5.1, and sodium was 139. We also ordered liver function test for him, which showed a rise in total serum bilirubin, which was 4.34, majorly contributed by indirect bilirubin. That was 3.78.
Mm-hmm.
And he also had raised LDH, it was around 2,300. And his coagulation mark parameters, PTN and APTT were normal.
बाकी तो बिल्कुल what LFT में
Yes, sir.
OTT
And yes, sir. His SGOT was raised, it was 97, and PT was around 18.
गामा दीदी Gamma G. नहीं देखा. Alkaline phosphatase.
I did not note it down, so it was.
Okay. No, I am sure it was reported. Is it important?
Yes, sir. But underlying liver disease, associated, it could indicate if there is any underlying liver disorder, liver disease, chronic, persisting.
So what do you expect alkaline phosphatase to be? High or normal?
So it could be either normal or high.
If it is high, then why?
Given child.
Hmm?
Given child also.
Alkaline phosphatase.
So AFP given child.
Yeah. Bone growth, okay. Bone specific alkaline phosphatase. Or
To differentiate obstructive
Pancreatitis.
pancreatitis. Or
to differentiate between obstructive versus hepatocellular carcinoma.
or कौन से आता है alkaline
So
phosphatase?
liver
Liver,
intestine,
intestine, pancreas.
liver intestine present and
RBC? नहीं आता है. Patients who are having hemolysis, they also have high alkaline phosphatase, but then they will not have high GTT. So that's how you differentiate whether this alkaline phosphatase is coming from RBCs or from because of liver dysfunction. Right? So just like as you see bilirubin, indirect hyperbilirubinemia and high alkaline phosphatase, with normal liver enzymes or normal GTT. Liver enzymes are mildly late, but you call them high when they are more than say 100 or something. So it's just mild.
This patient's ALP was 307 and GTT was 21.
20. Okay. Chalo. So, what else?
And to rule out the infections, we checked for his MP antigen, dengue profile, and the viral markers were also sent, which were found to be negative.
Right.
And we did a Darry-Coons test as well, that was also negative, and ASO titer was also sent, which was in the normal ranges, it was negative. And so we also did an ultrasound scanning, which showed a liver size of around 14 centimeters and mildly raised ecotexture. The kidney size, right kidney size was around 8.4 into 4 and left kidney was 8.4 into 4.3 with a mildly raised ecotexture, and he was also found to have minimal ascites on ultrasonography, and there were no evidence of other hepatosplenomegaly as such. And,
No abnormality in the urinary tract.
no, sir. And so these were the basic investigations we did, and we followed them.
What is the diagnosis now?
Sir, because
After these investigations?
yes, sir, there is anemia, thrombocytopenia, renal dysfunction, and peripheral smear shows schistocytes. So I would like to still keep my diagnosis as hemolytic uremic syndrome.
You need to send his stool for Shiga toxic?
So stool culture was sent and stool for PCR for
Shiga.
yes, sir.
Negative?
I didn't follow the report.
Chalo.
So recent admission actually.
Yeah, no, that's all right. So that logically that
Yes,
should be
sir.
followed. So clinically, yeah, fine. With investigation, you're pinpointing it. HUS, patient definitely has hemolytic uremic syndrome. So what is the reason for this hemolytic
Yes, sir,
uremic
yes,
syndrome? In absence of diarrhea, whether it was diarrhea associated or not, you should look for
Stool
evidence
culture,
of
that is PCR.
stool culture or Shiga toxin in
Yes.
the stool. Right? So what else? What else?
And so then we will be sending, we should send his complement factors, most importantly if we are considering an atypical hemolytic uremic syndrome. So, complement.
So just to add, like the patient you were treating, what was his urine output like during
Yes,
this
sir.
time?
So he did, although he complained of decline for just some time, but before presenting us, he was already given IV fluids. And
During hospital stay, like you must be monitoring the urine.
yes, sir.
output.
His urine output was around 1 to 1.5. I mean, 24 hours. It was around 1500 to 2 liters urine output.
He was passing 1500
Yes,
to 2
sir.
liters of urine.
Yes, yes.
Is it odd for HUS?
So there could have been a decline, but he had already received saline, and he was. That is why, considering his urine output initially, we thought that it could be even a.
So what is the pathology in HUS? So what is happening in the kidney? So that is going to tell you what the urine output should be in such conditions.
So there will be. It can present in 2-3 ways. Number one, it could involve the glomerulus. So there will be.
It involves the
Yes, sir.
glomerulus, so
Yes,
that
sir.
is the basic pathology.
Yes.
So what is happening in the glomerulus?
So there will be endothelial injury,
Yes.
and that is going to cause the
Complement
activation, resulting in the multiple in the accumulation of the inflammatory cells and damage. There will be endothelial swelling and also
So what happens?
thrombi formation.
Thrombotic microangiopathy.
Yes, sir.
So what will happen if the glomeruli are involved with the thrombotic microangiopathy? What you expect
There will be-
urine output and all?
It will be decreased, sir. Will not.
So in this
Because-
patient,
Yes.
we are saying that patient is passing 1.5 to 2 liters of urine.
You feel this is odd or this is normal? You were not surprised with this urine output.
No, sir. We were surprised with the urine output. We thought it will be less, but when we saw that it's passing at a bit, we didn't.
This patient has acute kidney disease. Within
Yes.
3 days, he has progressed to the stage where his
Yes.
serum creatinine is 3. So it's not like incidentally detected thrombotic microangiopathy.
Yes.
Patient has severe acute hemolytic uremic syndrome. Right? Generally, they have bilateral diffuse involvement of the glomeruli. Right?
So severe because the hemoglobin is 5.7.
Yes,
So the passing,
Cystocytes are so many.
passing good amount of urine with this type of renal injury is definitely very odd
Yes.
in this situation. So,
And what was the serial creatinine levels?
you said on admission it was 2.9, but subsequently?
Sir, it is more or less same, only 0.2 variations, 2.93, and as of today it was 3. It is 3 itself today.
Okay. So how did you manage it?
So we sent his, first of all we took the samples for the complement factors and antibodies, and then we started him actually on
What samples you have sent?
So we have sent the sample for anti-factor H antibody and for complement factor H, and we have sent clinical exome and
Only factor H?
factor H, factor I, and
MCP.
we
You have sent a panel.
yes,
You
so
have
the
sent-
panel actually, but individually we said
You did this complement level C3. What was the C3 level?
so C3 levels came out to be normal.
Normal. Is it odd or it is?
So it can be normal.
It can be normal.
Yes.
It's more or less it is generally normal. Very rarely it is low. So you started him on plasma exchange.
Yes.
How?
So we have done one plasma exchange for him yesterday. We started him on plasma exchange yesterday
Okay.
with 20 to 40 ml of per kg per kg. With a 20 to 40 ml per kg body weight and
कितना करा था आपने इसका?
2.5.
2.5 liters में डाला. 50
Yes.
किलोग्राम का है.
Yes.
तो फिर तो 50 ml per kilogram हो गया. 50.
So a little higher because for initial
Yeah,
sessions we
correct.
can keep a little high volume of plasma exchange in this.
That's all right.
Yes, sir.
So you removed the plasma and you replaced it with?
We replaced it with, since because he had thrombocytopenia and he was bleeding, we replaced it with FFP. I mean, we have given coagulation factor along with that. Sir, he had bleeding from the, actually we had inserted the femoral HD catheter, and from the suture side he has been having a lot of bleed. It was very difficult to control, so we had to replace it with all with the 6-unit FFP. We have given him 6-unit FFP.
Suppose he was not bleeding.
Yes, sir. Still, sir, we would replace the coagulation factors and we would replace it with FFPs. Plus, along with that, we have given him calcium glucose as somatic transmission. Yes.
Vitamin K and calcium.
Yes.
So usually in these patients, once you remove the pathogenic factors,
Yes.
that you also have to replace the normal
Plasma.
coagulating factors or complement. So it's always recommended to give them FFP rather than albumin. In
Yes.
other plasma exchange, we replace it with
Yes.
albumin. But in patients who have HUS or PCP, you have to replace the coagulation factor. So it's specifically presented effective. Suppose you do the biopsy in this patient, what do you find? So what are the biopsy features of HUS?
Will you do biopsy in this patient?
Usually biopsy is not indicated until if we are really very doubtful, we are very doubtful.
It is indicated.
It is doubtful.
So let me just correct you. No, biopsy is definitely indicated, but the diagnosis is generally made on clinical grounds, and you don't want to delay your treatment waiting for biopsy, right? Because otherwise, as you said, this patient was bleeding, his platelets are very low. You will give them platelets, you give them blood, and then do the biopsy. So you don't want to wait to establish the diagnosis by biopsy and then start treatment. So you start. Most of the time, that's how it happens. It is not that it is not indicated. It is definitely indicated. Okay, so as soon as you get an opportunity to do the biopsy, you will have to do the biopsy in these patients. So suppose the biopsy was done in this patient, what will you find?
So there will be endothelial swelling, damage. There will be ferment deposition, occlusion, and even because
How
of
will you
skin
from but what will you see on biopsy?
clots, hemorrhages,
Where?
glomeruli.
Glomeruli में hemorrhage.
I mean, sir,
Which part of glomeruli? Bowman's capsule? Glomeruli में तो capillaries होती हैं जहाँ पे already blood होता है, mesangium होती है और Bowman's capsule होता है. Hemorrhage दिखता है तो कहाँ दिखता है? Interstitium में दिखता है. So what is pathognomic of HUS or TTP
thrombotic
or TMA, whatever? How will it appear on microscope?
clumped
नहीं पढ़ा आपने. Fibrin thrombi. So you will see fibrin deposition in arteries, vessels, and in glomerular capillary loops. Plus there is mesangiolysis. Okay, so the capillary loops will be dilated because they are supported by mesangium. And in this disease there is mesangiolysis. So there is no mesangium to support the capillary loop. So dilated capillary loop with fibrin deposition in the capillary and mesangiolysis. Okay, and in severe form you may find hemorrhages in the interstitial hemorrhage. Right? Okay, good. Any other question? You have any other question?
So role of immunosuppressive.
So how will you manage, like how many plasma phases till when?
Till there is hematological resolution.
What will you form? How will you decide there is hematological resolution or not resolution?
The LDH comes in the normal range, the liver enzymes are in the normal range. The platelet count is more than 1 lakh.
So
Most
means
importantly,
your platelet count.
Follow platelet count and LDH. So if the LDH is coming down and the platelet count are rising, and the hemoglobin obviously is stabilizing.
There is no further evidence of hemolysis
Hemolysis.
that you find out by LDH and maybe cystocytes on the peripheral smear. So you will do daily, alternate day.
Initially, the plasma exchange should be done daily because it is an emergency condition. And once there is remission, then you should go in alternate days and then decline the frequency of the plasma exchange.
And any drug which is available for this
Yes,
kind of
if not plasmid, ideally nowadays it is considered eculizumab. The complement inhibitor is the to go for the treatment of the HUS, but in our scenario we do plasma exchange. But yes, eculizumab is indicated for the HUS. And also if you have done plasma exchange and there is no response observed, even then you should go for equilizumab.
How does equilibrium happen?
Sir, it is a complement inhibitor C5, so it is going to inhibit the cascade of activation of it will prevent the formation of membrane attack complex.
attack?
C567 the
Yes,
complement, membrane attack complex. That's what it will block. Complement blocker.
And also there is a role for immunosuppressive medications as well, Adam. If it is found to be atypical, if associated with complement factor H antibodies, should be given steroids and followed by after remission cyclophosphamide or rituximab can be given.
Generally required in TTP. Patients who have TTP that is activated by these antibodies. So in C3 complement, it is almost 50% patients you may find the genetic defect.
Yes.
In rest 50% you may not find a significant genetic defect. Eculizumab is a terminal pathway blocker, so you will block the injury which is occurring because of any reason. It's a self-limiting disease. Once your acute precipitating factor or second hit is gone, it will get stabilized on its own. Not much role of immunosuppression, although people might have tried steroid and other things, but there is no definite role of immunosuppression in atypical HUS. There is no point loading them with. Any other question?
So is there any histological difference between typical and atypical HUS over the both?
Generally not.
Pathology remains the same. So the prognosis of diarrhea-associated Shiga toxins, they are better, obviously. So, and the prognosis in atypical is not that great. So 50% of the patient progress to chronic kidney disease, and then eventually the progression of the CKD. So that is the.
Generally, that if suppose this is diarrhea associated HUS, what will you do? Will you manage it differently?
Yes, sir. Usually diarrhea-associated HUS, they have a spontaneous recovery. We have to give a ample amount of, or we have to go for a fluid resuscitation basically.
So just a supportive treatment
Yes,
is required in diarrhea associated. Once the diarrhea is controlled, they are self-limiting and they get better. And as Dr. Nandwani is saying, they recovers completely generally. There may be some residual injury if the patient has a severe diarrhea associated HUS. So you have to follow these patients in the long run. They may again go into chronic kidney disease subsequently. Whereas patients who have atypical HUS, generally the prognosis is not that good. So there may be some partial recovery or no recovery at all, and they may end up with advancing and failure very soon, if not treated in time. The treatment is definitely eculizumab is the drug which can limit the injury to the kidneys. Thank you.
Thank you, sir.
But you need some improvement in history presentation. Generally, I don't know whether this is a universal. I find you present the same time when you start with negative history. No history of this, no history of that, no history. First, complete the history. Complete the course of presentation of present illness and then come with the negative history. Okay, these are the things which are in my mind. And that's why I elicited this history as a negative history.
And in nephrology, whenever you are giving the diagnosis, as I was telling, give syndromic diagnosis first. Whether it is acute kidney injury, whether it is nephrotic syndrome, or whether it is chronic kidney disease, and then go to the etiological and then histopathological diagnosis. Like in this patient, acute kidney injury, HUS, thrombotic microangiopathy on histopathology. So that should be your complete diagnosis at the end of the case presentation. So that is
how you
the
proceed
format.
as well. So that's how your mind works. Whether I'm dealing with a acute disease or a rapidly progressive disease or chronic kidney disease, or if acute disease, what type of injury I'm dealing with. That's how you narrow down your diagnosis.
So initially you had the idea of like lupus also, but then you should have something positive in that support. Like in the history there was nothing. 13-year male child. Okay, and there is no history of any suggestion of joint pain. Lupus, usually this kind of acute kidney injury is not the presentation. It can happen because lupus emergencies are also there. I am not saying that cannot happen, but obviously you have to present the clinical part without investigations first. So you should analyze the history part supported by the examination. That should come into your diagnosis. So you should have the supporting evidence from the history for your diagnosis. So otherwise, chronic kidney disease also comes into the picture and all those things. So they are very lower down in such patients with such a short history.
Thank you.
Thank you.